That's wonderful summary. Thank you very much, Samresh. And our next speaker, of course, needs no introduction anywhere in the world, Dr. Ramamurthy sir. He's been kind enough to be a part of this course for the past several years. And I think all of us are going to enjoy his pearls of toric IOLs and how he goes about them. Over to you, sir.
Thank you, Shail. I truly deem it an honor to be called every year for this course. I've learnt a lot over the years from Dr. Abhay and now from his the next generation. And no, I don't have any audio. This is the topic that has been given to me, tips and tricks for success with toric intraocular lenses. I think in the last half a decade or so, our very understanding of toric intraocular lenses has undergone a sea change. You might have reservations about taking on multifocal intraocular lenses, but I think in today's world you can't do cataract surgery without incorporating toric intraocular lenses. Three fundamental issues which have changed are our understanding of posterior corneal astigmatism, the surgically induced astigmatism, and toricity ratio. Let me very briefly dwell upon these things. It was the work of Graham Barrett, Doc Cock, etc., which showed us that the evaluation of the posterior cornea is as important as the anterior cornea. We did not know much about it, we were not measuring it, our machines did not know much about it, and we were not looking at it. But now we believe that the posterior cornea is most often steeper vertically, and it's to the extent of about minus 0.3 diopters to minus 0.5 diopters. So whenever there is against the rule astigmatism on the anterior surface, it adds to it, and when there is with the rule astigmatism, it sort of reduces it. And also this posterior corneal astigmatism does not change with the age of the patient, but remains constant right from a young age to older age group. Another very important factor that we need to understand is that the anterior corneal astigmatism shifts over a period of time. It's to an extent of about 3/8 of a diopter for every decade of the lifetime of patient. That's why you'd find that most of our LASIK patients come with the rule astigmatism, while most of our cataract patients come with against the rule astigmatism. So obviously, if it's a young patient presenting, say a pediatric cataract presenting with the rule astigmatism, I would be wary of taking on that patient, because not only is it going to change with time, but the posterior corneal astigmatism is also going to partly compensate for that, and this is something you need to keep in mind. This is exactly that's mentioned here. The calculator must essentially give you choices as to what exactly is the toricity that you need to incorporate it in this intraocular lens. The other important factor is that we all understand the concept of effective lens position as far as spherical intraocular lenses is concerned, but the same is also comes into play when it comes to the toric intraocular lenses. We have understood that for about 1.5 diopters of toricity is what you require at the intraocular lens plane to get 1 diopter of correction at the cornea. But that relationship is not constant. When you come to extremely short eye, hyperopic eyes, it might be just 1.2 diopters. And when it comes to very myopic eyes, it might be almost 1.75 diopters. And this is something we need to keep in mind. Look at this chart. This essentially tells you if it's a steep cornea with a short eye, you just require about 1.3 diopters in the lens to correct 1 diopter in the on the cornea. While if it's a flat cornea with a long eye, you require almost 1.86 diopters. It stands to reason, it's intuitive, simply because depending upon the position of the intraocular, in short eye is going to be anteriorly placed, in long eyes it's going to be fairly placed at the back, because of which the effect of the lens will also be minimal as far as the toric correction is concerned. Then comes the most important concept of surgically induced astigmatism. Till around half a dozen years back, I thought my 2.4 or 2.2 millimeter incision induces about 0.4 diopters of astigmatism along the axis in which I place it. I used to even make my incision based upon the amount of astigmatism I am dealing with. Seminal work from people like Doc Cock has shown that the astigmatism has not just magnitude but also direction as well as magnitude. Over different points on the cornea, they tend to compensate for each other. So a sub 2.4 millimeter well done temporal clear corneal incision just induces about 0.1 diopters of astigmatism. So either you can feed in just 0 or just put in 0.1 diopters. So I'm still quite surprised to listen to some of the good speakers talking about SIA calculation. I think today's world is redundant, and you can as well assume that if you are doing a 2.2 to 2.4 millimeter incision, there is no astigmatism that's being induced by your corneal incision. If you're going on to 2.8 or 3 millimeters, it might be to the value of about 0.25 diopters, but that's something you need to keep in mind. Samresh already mentioned about this suite of formula. Multiple different excellent formula available, but I can't give you all the options and ask you to choose. Basically, last about half a dozen years, again we are stuck on to this simple single formula, suite of formula, the Barrett Universal 2 formula, which gives us the spherical value, the Barrett toric calculator for toric intraocular lenses, the True K for the post-refractive surgery, Barrett RX formula whenever there is a residual cylinder after a toric intraocular lens implantation, and a toric True K calculator in case I need a toric IOL after refractive surgery. The go-to formula today when my patient comes into my clinic is not Barrett Universal 2, but Barrett toric calculator. That immediately tells me whether the patient primarily needs a toric lens or not. Because what we experienced earlier was there was not much corneal astigmatism, there was not much astigmatism in the glasses. Patient used to agree for a multifocal intraocular lens. Then we put him on the biometer and find that the patient has a significant toricity. So today the first thing we do is to go ahead and look at the Barrett toric calculator, then counsel the patient according to whether it's non-toric or monofocal toric or multifocal toric, so that you are not changing your words once the counseling has started, and it seems to work very well. As was just now asked, I believe that you can go ahead and implant intraocular multifocals as well as torics without the need for these equipments. But if you had to ask me whether I have to invest between upgrading from a medium level phaco machine to a high-end phaco machine, or should I invest in an optical biometer, I would say go for an optical biometer. It's not that one particular company biometer only works. There are several different options in various centers. We have almost all of this, and we find that it gives comparable results. So look at the economy, and in case it works for you, please go ahead and invest in an optical biometer. I think it's money well spent. But just in case you are in a position where you are still not accessible to it, that does not mean that you cannot take benefit from this Barrett formulae. It's available both at the ASCRS, APSCRS websites. This is right in the opening page, the home page of the APSCRS website. Some of the formulae like the Barrett RX formula, Barrett True K is not actually available in the optical biometers, but is available in the websites. So even in our centers where we do not have optical biometers, small centers, we take from the immersion A scan, we take from the keratometer, and then input the data on these instruments, and so as to on this formula, so as to get the benefit of this formula. Again, in case you are using a standard intraocular lens and you give to a company calculator like this, again these factors are taken into consideration. It's not just for Alcon, most of the companies take this into consideration. You can see the axial length is taken as 23.5, anterior chamber depth is taken into consideration. That's because the toricity ratio, depending upon the axial length and the power of the primary power of the lens that you are implanting, the power of the toricity is going to change. The surgically induced astigmatism, as you can see over here, is taken as 0.1. And again, the K index can be variable depending upon the particular instrument that you are taking, using to check your keratometry. And that's again something you can put in so as to get the perfect values that you need. So the Barrett toric calculator seems to work very well. I don't want to go, there are several other different formulas that are available, but you need one formula, one suggestion that you can go ahead and practice tomorrow. And the reason I go for this is it takes into consideration posterior corneal astigmatism. It takes into consideration the effect of the against the rule drift that occurs over the period of time for the patient. It targets 0.25 to 0.5 diopters of with the rule astigmatism. Takes into consideration the basic axial length and the intraocular lens spherical power, so that the toricity ratio is incorporated. You can put your centroid value as 0.1, supposing you are doing a sub 2.4 millimeter incision. Again, the K index is again something you can factor in. Then came the concept of total keratometry. Because of the telecentric keratometry and Swepso's OCT, you are able to exactly measure the thickness of the cornea, and because of this extrapolation, you are able to get a actual curvature measurement of the posterior corneal surface. And you have both the anterior cornea and the posterior cornea, unlike in the original Barrett formula where it was a mathematical assumption. Here actually you are able to exactly measure the anterior and posterior cornea and arrive at the arrive at the formula, and that's the reason you have various formulae like the Barrett TK universal 2, the Barrett TK toric, Barrett TK true K, etc., where it's not just the keratometry of the anterior cornea, but both the anterior and the posterior cornea is taken into consideration. But having said that, it might result in somewhat better results as far as toric intraocular lenses is concerned. But in the run-of-the-mill universal 2, or if you are just looking at the spherical power, it's been documented that just using a TK does not have significant value. But in case you are thinking about post-refractive surgery eyes, then the relationship between the anterior cornea and the posterior cornea is completely changed, and that's the reason that putting in a using the TK would be a good idea, because it actually measures the posterior corneal surface. I'm not going to go into the details of marking, but stick to one, adapt one. In case you can afford a digital marking device, it's again a good investment. But then once you have mastered a particular technique, I have done live surgery in different centers, I find that each center has its own marking device and the surgeon swears by that. So do not experiment with too many centers. Go ahead and have a look at them. Whatever works for you, go ahead and use it, and you will find that it functions quite well. It's a very short video of a toric intraocular lens implantation. That's the side port incisions that I make, then the main port, and then basically the lens is removed. That's not vital for this talk. Then subsequently, having a good 5 mm rhexis is extremely important, so that you have a good overlap of the rhexis margin. And this is an intraocular lens, single piece intraocular lens, which goes in through a 2.4 mm incision. I've shifted over from 2.2 to 2.4 mm because I don't want to stretch my incisions. Removing viscoelastic quite completely, both in front of the lens and behind the lens, is extremely important. Nowadays, I more often do a hydroimplantation so that there's no viscoelastic. And then you can see the aspiration cannula going behind the lens and removing the viscoelastic quite completely, because if you leave behind viscoelastic in the eye, there is a propensity for the lens to rotate in the postoperative period. And it's also a good idea to polish the rim of the anterior capsule, though it's not absolutely important, so that there's no tendency for a capsular phimosis. But having a good overlap of the rhexis margin onto the lens is important. Once you have removed the viscoelastic quite completely, you can rotate the lens in such a manner that there is good orientation of the lens. It's not that you need a digital marker to go ahead and do these toric intraocular lenses. We have this in a couple of centers only, but all my surgeons are actually practicing toric intraocular lenses with good results. And as far as the Barrett RX formula is concerned, it's extremely important that in case you get suboptimal results, what exactly do you do? If it's rotated by 15-20 degrees, maybe you will take up the patient even the next day and put the lens back into position. But if in case it's a small amount of astigmatism, it will get corrected only if the value of the residual refractive error is almost zero. The spherical equivalent to the residual error. That is, if it is -1 with 2 diopters of cylinder, rotation of the lens is going to help. But if it's simple -1 diopter of cylinder, rotation is not going to help, simply because when you are rotating the lens, there is no, you're not adding or subtracting any power, but just redistributing the power. So basically, these are the three options that this formula gives you, whether it's IOL rotation, IOL exchange, or a piggyback intraocular lens. This is the kind of actual scenario that we came across, a +24 T4 lens being implanted. We had a +1 with a -2.5 diopter of cylinder. So obviously the spherical equivalent is almost compensated. So rotation is going to help. And this is what we found, that the rotating the lens by about from its present axis to about 177 degrees would help, and that's exactly what we did. Just in case I had to exchange the lens, because there was a large amount of astigmatism, what exactly is the power of the lens that goes in is also represented here. In case it's a long-standing intraocular lens and you just want to go ahead and implant a second lens over the eye, again the power of the piggyback lens again can come in. As far as toric intraocular lens repositioning is concerned, it's a very quick procedure. I do not use any viscoelastic alone. Just go in with an irrigation cannula, and with the irrigation flowing, you just reorient the lens so as to it coincides with the exact position where you want. You saw that the lens was slightly rotated, and you do not use viscoelastic, because just removal of the viscoelastic or sometimes leaving behind some viscoelastic might itself compromise the kind of results. And this is the kind of simple procedure, 2-minute procedure you can do to compensate for that. Couple of examples. I think it's important that when you're going ahead with multifocal intraocular lenses, even low levels of toricity has to be addressed. This is a case when Panoptics has just come into the market. Panoptics toric was not available. This patient had a 0.87 diopters of against the rule astigmatism. We implanted a Panoptics lens expecting excellent results. Patient was very happy as far as near vision was concerned. Distant vision was quite unhappy, has about 612 parts vision, needed a significant astigmatic correction. And why we said we will do it on the cornea 3 months later. While waiting, he agreed to get the second eye done. And this is what we found, almost exactly the same amount of cylinder, but went ahead and implanted a T3 toric intraocular lens. And what you find is that the patient enjoyed excellent visual outcomes, both for distance and near, because the cylinder has been taken care of. 3 months later, we went ahead and addressed the residual cylinder in the first eye using a laser. And this is just to tell you that with the rule and against the rule astigmatism are totally different animals. When you use the toric calculator, this is a case of against the rule astigmatism. Just for a sub 1 diopter of astigmatism, the calculator shows that the patient requires a T4. But look at this example where it's with the rule astigmatism, 0.75 diopters, but the patient requires just a non-toric intraocular lens. I am often asked, what is the level beyond which you will start implanting toric intraocular lenses? Please don't hazard a guess as far as the number is concerned. Feed this data into your toric calculator and let the biometry tell you whether the patient needs a toric intraocular lens or not. Final points I want to leave you behind is tips to maximize outcomes with toric intraocular lenses. Multiple measurements of keratometer, whatever be the modality you're using. Consider the refractive cylinder, but be not guided by that because it could change. Check the ocular surface, like for any lens, it has to be optimal. Enter the measurements immediately. Take the surgically induced astigmatism of just 0.1. Undercorrect with the rule, overcorrect against the rule. But when you're using formula with the Barrett toric calculator, this is not really necessary. The final slide. During surgery, a little longer incision so that you have a very stable anterior chamber. Avoid overinflating because if there is too much fluid, then the lens tends to rotate. For the same reason, ensure complete visco removal. Nudge the intraocular lens onto the PC so that it rests on the posterior capsule. Make a slightly smaller rhexis so that there's a good overlap of the rhexis onto the optics of the lens. Ensure that the position of the lens remains stable even after the speculum is off. And in case if there is residual astigmatism, use the Barrett RX formula and re-rotate the lens. Thank you so much for your kind attention.
Thank you so much, sir, for that wonderful masterclass on toric IOLs. Sir, I had a couple of questions. As far as your incision goes, do you now in your current practice change your incision based on the steep axis?
No, not at all.
Yes.
I mean, I've actually increased from 2.2 to 2.4 because easier passage of cartridge and but it's always temporal clear cornea.
Correct. So I think the take-home message is that don't chase the steep axis, as sir very correctly showed. That astigmatism is not just magnitude, but it is also axis. So the vector relationship doesn't go as linearly that if it is superior, if you make a superior, it will flatten more and things like that. So stick to one incision and follow those refractive outcomes and then base your cases. And so the second question was, in a toric IOL post-operatively, do you suggest anything different to the patients? Because Dr. Osaka very nicely showed in one of the videos that he asks his patients that because it can rotate in the first few hours to take it easy first day or something.
I think it's an excellent question. I mean, what has been shown is most of the rotation happens within the first 1 hour of implantation. He has followed up serially from 1 hour to 6 months. And almost 80% of the eyes, the rotation happened in the first 1 hour. So obviously, the only thing I could practically do was to patch these eyes and ask the patient to immediately shift to the room and lie down for, usually we tell them you can go home immediately. Ask them to lie down for about 2 to 3 hours. And then subsequently, when I see the patient downstairs, post-operative, then remove the patch and send them home. My non-toric cases, I don't patch them, I patch them. I've not really done a study to see whether it has an impact. But practically, that's all I can think of doing. But the fact you have to remember is that if the lens is in position an hour later or on the first post-operative day, is most likely to remain in position in the subsequent period, subsequent visits.
I think this is a very interesting area, and thank you so much. Osaka showed, as DR said very correctly, that the chances of rotation are in first few hours. So he, like him, does not allow the patient to drive the car straight and sort of give the impression that you can go to the office and so on, because he showed very clearly that evidence that the rotation does occur if you allow them. So he actually makes 6 hours lying down for a toric IOL. I'm surprised. I don't do that, but that's what he does. And he also showed that if you rotate in first week or two, re-rotate the grossly aligned toric, the results are not good. Wait for 17 days. In his study, he showed waiting 17 days later on correcting, and before, waiting is a superior thing. So do not jump into rotation, because the capsular bag adaptation, the epithelial reaction, the chamber formation takes time. So thank you so much. I'm very happy that you are the only one probably who practices this. Wonderful.
Thank you.
Thank you.
Do you also patch the
No, I don't do whatever Osaka said, and I'm sure he's right, but the way I have projected the surgery in my practice, I'm not doing it. I should be doing it, but I'm not doing it. I'm very honest. Right. But I do say that can I do this? Not today. Take 2 days off, stay home and enjoy. I said indirectly, but I don't have still a courage to tell that this surgery requires lying down and staying home and so on, because this is contrary to what I have practiced. So I'm not doing it, but we should be doing it if
So
you really
I
want to do
allow
it. So go there and see what he does and follow that.